Hey everyone, all you future nurses out there. If you're getting ready for the NCLEX, you know that pharmacology can be, well, a total beast. So today, we are going to zero in on some of the most high-yield chemo drugs you've got to know cold. All right, let's get into it.
So let's just dive right in with a classic NCLEX style question. Picture this. You walk into your patient's room, they're getting methotrexate, their platelet count is way down at 40,000, which is dangerously low, and they tell you their gums are bleeding. What do you do first? So what's your priority action? Just let that sit in your brain for a minute. Don't worry, we're definitely coming back to this one. That scenario isn't just some random test question. It's a real-life emergency. It's that moment where a great nurse really shines, right? Spotting that danger and acting fast. And that is exactly what the NCLX is built to test. And that's exactly why we're digging into chemo today. Questions about these drugs are pure NCLEX gold. They don't just test if you memorized a fact. They test how you think when the pressure is on, which, let's be honest, is the heart of being a great nurse. Think about it. Just one of these questions can test your pharmacology, your safety knowledge, and your ability to prioritize, all rolled into one. If you can master these drugs, you are mastering a huge, huge piece of the exam. Okay, so to get a grip on all those side effects, the ones that are going to drive our priority questions, you first have to understand the mission. The whole point of chemo is to kill cancer cells. And what defines cancer cells? They grow fast and out of control. So how does chemo stop them? So it all boils down to the cell cycle. The process all our cells use to make copies of themselves. Chemo drugs are basically designed to throw a wrench in that process. But, and this is the big but, chemo isn't very smart. It's kind of like a bulldozer. It just takes out any cell that's dividing quickly, not just the cancer ones. And that's the key. That's why it also attacks our healthy, fast-growing cells, like in our hair, our gut, and our bone marrow. And that perfectly explains those classic side effects: hair loss, nausea, and that really dangerous bone marrow suppression. All right, so you've got the basic how it works down. Now, let's get into the code red stuff. The you absolutely cannot miss this safety alerts. These are the non-negotiables that can make all the difference.
All right, first up on our list, methotrexate. This is an anti-metabolite, and the main thing you need to burn into your brain is that it works by blocking folic acid. See, cells need folic acid to build new DNA. So if you block the folic acid, the cancer cell can't make new DNA and it can't replicate. Pretty straightforward, right? Okay, so what do you really, really need to worry about with this drug? Topping that list, right at the very top, is bone marrow suppression. This just tanks your patient's white blood cells, red blood cells, and platelets. That means a huge risk for infection, for anemia, and for bleeding. That's always going to be our #1 priority. You also have to watch out for liver damage, those really painful mouth and GI sores, and even lung damage. Okay, this next part is a memory trick you cannot afford to forget. Seriously, for methotrexate, you have to know its antidote, leucovorin. Think of leucovorin as the rescue squad. While methotrexate is out there carpet bombing all the fast-growing cells, leucovorin comes in and protects the healthy ones. I'm telling you, you're going to see this pair on your exam.
And here it is, a classic textbook NCLEX trap. Listen up. Your patient on methotrexate is in pain, and a doctor orders an NSAID like ibuprofen. This is a massive red flag. Why? Well, both of these drugs try to leave the body through the kidneys using the same exit door. If you give them together, they cause a traffic jam. Methotrexate gets stuck inside, and its levels can shoot up to toxic levels. And that's where you, the amazing future nurse, step in and say, hold on a second, you have to question that order. So circling back to that severe bone marrow suppression we talked about, especially that huge drop in white blood cells, we have to talk about neutropenic precautions. This isn't just a good idea, it's a fundamental safety standard for these patients to keep them from getting a deadly infection. The NCLEX is going to ask about these, so let's lock them in. Here are the top 4 you've got to know. Your patient needs a private room. Everyone, and I mean everyone, uses strict hand hygiene. Absolutely no fresh flowers or plants. They can carry fungus and bacteria. And they need to avoid raw foods, like salads or any undercooked meats. Okay, drug #2 on our hit list. Let's talk about cisplatin. The way to remember this one, think heavy metal. It's actually a platinum-based drug that gets inside cancer cells and basically tangles up their DNA so they can't replicate. Okay, look at this picture. This little cartoon guy is going to be your best friend when it comes to cisplatin. It's an amazing memory tool. Just look at him. You see the crying kidneys? That's for severe kidney toxicity or nephrotoxicity.
He's covering his ears, which stands for ototoxicity, hearing damage. And of course, that look on his face is for overwhelming nausea and vomiting. Boom. Kidneys, ears, nausea. That's your toxic trio, right there.
See how that works? Once you know the toxicities, the nursing actions just make sense. To protect those kidneys, we hydrate, hydrate, hydrate. We're talking 1 to 2 liters of fluid before we even start the drug. For the nausea, we get ahead of it and pre-medicate with antiemetics. And we are constantly checking labs like BUN and creatinine. And we're always asking our patient, hey, have you noticed any ringing in your ears?
All right, time to put this into practice. You're the nurse. You're getting a couple of bad signs at the same time. How are you going to decide what's the most important thing to do first? So here's the scenario. Your patient on cisplatin tells you they have new ringing in their ears. Then you check their urine output and it's only 20 milliliters an hour for the last 2 hours. Okay, so you've got 2 alarms going off at once. Both are bad, right? Part of that toxic trio. But which one's going to kill your patient faster? The ringing ears, the ototoxicity, that's serious for sure. But that dangerously low urine output, that's a sign of acute kidney injury happening right this second. That is the immediate threat to their life. So you got to act on the kidneys first. Okay, you guys did great. Let's hammer this home with a quick, rapid-fire review. These are the things you absolutely have to walk away with for your exam. First thing, methotrexate. Your brain needs to just scream. Bone marrow suppression. That means infection risk and bleeding risk. Number 2, cisplatin. What are we thinking? We're thinking that toxic trio, but the big ones are kidney and ear toxicity. Always.
Number 3, that antidote. You've got to know it. Leucovorin is the rescue drug for methotrexate. Lock it in. 4, what labs are you watching like a hawk? For methotrexate, it's that CBC. For cisplatin, you're all over that BUN and creatinine. And last but not least, I'm going to leave you with this question. Remember our patient with that super low white blood cell count? If they spike even a low-grade fever, it is a full-blown medical emergency. What is the absolute first thing you would do? Seriously, think about it. If you don't know, look it up, because that's the kind of quick thinking that saves a life. You got this.